This video will supplement our cerebral palsy video to add in a discussion of brachial plexus birth palsies. So for a discussion of cerebral palsy, please see the video above. For the brachial plexus birth palsies, let's dive into it. So we're starting off at main point 3. Alright, brachial plexus birth palsies are exactly as they sound. So during birth, there's damage to the brachial plexus. Usually this is caused by some kind of stretching during a difficult delivery. It causes either stretching or, in more severe cases, rupture of the nerve or nerve roots. So the brachial plexus is something that should be near and dear to your heart. The brachial plexus contains 5 roots, C5 to T1, which are going to innervate the upper limb. So innervation of the shoulder on down to the hand. In general, higher up roots are going to hit higher up in the limb. And as we get down into the most distal portion of the limb, those will be the lower nerve roots, but it does a bit of a wraparound. We could have damage anywhere, either at the level of the root, or it could be the trunks, so it could be within the brachial plexus. When we have damage here, we're going to see unilateral upper limb weakness. And that's the characteristic feature of brachial plexus birth palsies. The incidence is somewhere between 50 to 200 per 100,000 live births. The major risk factor here is macrosomia, so a large baby, greater than or equal to 4 kilograms at birth. This, of course, leads to difficulties with removing the baby during birth, so a little more suction or pulling might need to be applied. That can then pull, creating tension and potentially damaging nerve fibers in the brachial plexus when we're yanking the baby out of mom. There are other potential sources of a difficult birth, such as having multiple births, twins, triplets. Of course, the risk of having a large baby, well, part of that can just be that it runs in the family. Of course, maternal obesity and diabetes are risk factors for macrosomia, so those are additional risk factors for brachial plexus birth palsies. There are 3 different types of brachial plexus birth palsies. There's the Duchenne birth palsy. That affects the roots C5 and C6, so high plexus lesions. That's going to affect then the shoulder and upper portion of the arm. Klumpke birth palsies affect the lower plexus, so C8 and T1. That will affect more so the wrist and hand. Be a little contracture at the elbow though. Or we could have both, what we call whole arm birth palsy. So that's C5 to T1, so from the shoulder down to the hand, we're going to see weakness. So with Erb's palsy, that's again C5, C6, we're going to see weakness in the shoulder and upper limb, so poor biceps function. The weakness in the shoulder causes it to rotate inward. And then the hand tends to curl back like this, and what they're calling the waiter tip deformity. So we'll see more of this with higher plexus lesions. Lower plexus will leave the shoulder and upper arm just fine, but we're going to affect the distal muscles. So the hand will be affected. So we'll have general weakness in the hand, so all the connective tissue there is going to kind of just curl the hand up into kind of a claw. And we'll see bending at the elbow and turning of the wrist. So I have an upward turn wrist there. So this will be more characteristic. If it's whole arm, we'll see weakness from shoulder to the hand. Now, 2 problems occur with brachial plexus birth palsies. First, there's the initial insult, the stretching of the nerve fibers. The stretching could just tear the axons. That would be bad. or it could tear the axons and the connective tissue. That's even worse. If we just stretch the axons, recovery can occur in the absence of any surgical intervention. If we rip the nerve fibers, though, surgery is required for reinnervation to take place. The good news here is that we're dealing with peripheral nerves, so regrowth is possible. Now, we're also dealing with damage during the developmental period. So, not only do we have the initial insult that causes weakness, we've also impaired our sensory motor function during the developmental period. So, how well we learn to use our arm is impaired. So that creates a problem. We have to figure out, how do we even move this thing in 3 dimensions, and how can I map this in my cortex so I know when things are touching my arm. These brachial plexus birth palsies thus have 2 hits. There's the initial damage, and then there's the delayed development because of the damage of nerve fibers. So our ability to use the arm is impaired immediately and afterward because of effects on development. As far as diagnosis goes, it's really all about imaging. We need to see signs of damage in the brachial plexus. Now, this image over here is clearly not a brachial plexus birth palsy because it's from a 43-year-old woman, but it does allow us to see how stretching can cause the swelling of nerves, and we can see that on MRI. So in this case, same idea. We got some traction injury, not at birth, but later in life. Doesn't matter, we can still see it. So when we damage the nerve, when we pull on the nerve, we stretch that out. What that's going to do is pull on all the axons running in the nerve. These might break if we stretch it too far. So they've kind of popped. Of course, there's no pop in apoptosis, but there sure is in necrosis. So we're going to deal with necrotic loss of our axons there. That leads, of course, to inflammation. So we're going to get swelling at that site. And so we'll be able to see these enlarged nerves, either nerve roots or the actual nerves themselves, depending on where the damage occurred. So we might very well see some inflammation. We might also see signs of skeletal deformities, and radiographs are particularly useful. In this case, they really make bone pop. So we might see some developmental irregularities, maybe an extra rib or something like that. We might also see fracture, showing a sign, yes, there has been damage in the area. Imaging is also useful for ruling out other causes. Maybe it wasn't having to pull on the baby to get it out. Maybe it's bad luck. There might be some sort of abnormal growth within the brachial plexus there that puts pressure on these nerves, and that is what's creating our upper limb weakness. As far as figuring out which muscles are affected, EMG is useful at 4 or more weeks of age. So that can help us pinpoint which muscles are actually deinnervated. As far as distinguishing whether we have the loss of axons or whether it's just conduction block, we can do nerve conduction studies by stimulating at different sites before and after the injury to see if we still have axons there. So if we have damage to axons, and this, let's say, ran over and innervated some piece of skin, if I've lost my axon, this is going to degenerate. So stimulating at the site of innervation won't give me any sort of action potentials that I can measure. On the other hand, if it's just maybe a little pressure pushing on the nerve, so I haven't lost my axons, but I'm blocking conduction because of some abnormal growth. And so rather than breaking my axons, in this case, well, I guess that'd be in the dorsal root ganglion or something, that pressure can be enough not to kill the axon, but to kill the myelin. So we might just get a little demyelination. In that case, I still have an axon intact, so if I were to do a nerve conduction study where I record here and stimulate over here, I'd still pick up an action potential, showing me that there are axons in this nerve. Over here, if I've severed them and I actually have the loss of axons, now when I do my nerve conduction study, there are no axons to give me action potential. So I can stimulate all I want in that terminal field, I won't detect action potentials. If it's just some pressure, we haven't killed off the axons, we'll still be able to detect a sensory evoked action potential. But that's a minor point. The major point here is that we want to see signs of damage. MRI is a really useful tool for looking at nerve damage. As far as skeletal abnormalities, you can use MRI. X-ray is a little bit better. It's faster and cheaper. Okay, treatments. Well, if we have rupture, let's say of the nerve itself, let's say the whole nerve popped, well, we have to have surgery. No ifs, ands, or buts. This will not heal on its own. So neurosurgery is very useful in those cases, especially early on. It needs to be within about the first year of life. We want to restore proper innervation of the muscles, skin, and joints so that we can learn how to use our arm properly. So early neurosurgery is quite helpful. Here we can see how effective early neurosurgery is here. So here they're just looking at elbow flexion strength. 0 meaning you have absolutely no strength. 3 meaning normal in this case. So they're looking at outcomes in less severe cases, those that didn't require surgery, and more severe cases, those that required surgery and got it. And what they're showing here is that early on, so before the operation, there was a big difference between their groups. They took children who had no elbow flexion strength. And then after surgery, so now looking at 2 years of age, most of them have achieved a normal level of elbow flexion strength. Some still have 0, but most showed good recovery. So early surgery is important in those more extreme cases of damage. If proper innervation doesn't occur, later on reconstructive surgery might be necessary to restore some movement in the shoulder, for example. So if some muscles remain de-innervated, we can do tendon transfers, for example, to allow other muscles to pick up the slack of that de-innervated muscle. Of course, regardless of whether we're dealing with early or late physical therapy is going to be important here for improving range of motion, strength, and in case any contractures occur. So if normal function is not restored and we have weakness that persists, well, then we're always worried about contractures developing because we're not using the muscle properly. And that's where you all come in, doing whatever it is that you do. As far as the prognosis goes, well, it's actually pretty darn good. The majority of cases will have near normal function, and almost all of the rest of them have a good outcome. So usually there's a happy ending. As far as recovery goes, it starts more distally and then moves back to the proximal muscles. Signs of good or bad outcome kind of depend on where did the damage occur. If it only affects C5 and C6, so if it's an upper plexus injury, that tends to be better than the lower plexus injuries, and that's good. Higher plexus injuries, those are the majority of cases. Also improvement. Regardless of what we're talking about, doesn't matter if it's a brachial plexus birth palsy or a stroke or autism, doesn't matter. Seeing early improvement is a good indicator of later outcomes. Put a little differently, a lack of early improvement is a good indicator of poor outcomes. So, we would want to see some improvement after either surgical correction or whatever it may be, most likely surgery. We'd want to see that, okay, after correcting the damage, now we have biceps function returning, right, within about 3 months or so. If we don't see that, if we see poor improvement after 6 months, well, that indicates we're not likely to regain our function. So in that case, we might need to worry about some follow-up reconstructive surgeries, or maybe having risk of contractures develop. So we might have a lifelong therapy in our future. Alright, so just a quick video to touch on brachial plexus birth palsies. If you have any questions on this or cerebral palsy, please fill out the questions box. Don't email me like the other video said. That was made in simpler times, before I had the questions box. But we got it, so use it. See you later.